Thank you. My name is Micheal Robson. I'm delighted to be sharing this conference and presenting to this conference with you. And hopefully what I have to say is going to be useful or interesting. My title is The Concept of, is there an optimal cesarean section rate? We all talk about reducing cesareans, but I think the terminology should be more changed now to, is there an optimal cesarean section rate? And that's what I really want to talk about. The whole debate about cesareans, a lot has been written, but it's very difficult in my view to conclude that any consensus, anything of value has been achieved on the subject. And I think as professionals, we have a duty now to completely rethink our position on cesarean section rates. For a start, is a cesarean section an event, just something that happens with neutral, no issues with it? Is it an outcome that we get judged by? Is it an intervention, whatever that is? Because to some people, what is an intervention is not to another person. Or some people would even regard it as a complication. And I think we have to have those discussions. It could be any of those, I suppose, in theory, but it depends on your view. And the biggest criticism we will face as professionals in the future is not that the cesarean section rate was allowed to increase, but that we made no effort to study it or its implications scientifically, either in the short term or indeed the long term. The cesarean section and the cesarean section rate is the fulcrum on which all other events, outcomes, interventions, complications, organizational issues in maternity care, but labor and delivery are related to either directly or indirectly. It's a really important event for organizational reasons as much as clinical reasons, and it plays a central role. Many people have asked, has the cesarean section rate as a number become an obsolete statistic? And this is a recent article from the British Journal, and time to forget about cesarean section rates. But as an overall rate and on its own, I feel it's always been obsolete. But understanding it in a structured manner and relating it to other short and long-term events and outcomes, I think is more important now than ever. So it's not whether your section rate is too high or too low, but more about, do you know what it is, why, how it's changing, and what, if any, other short and long-term consequences. It's going to be much more of a flux, an event in flux and changing all the time. And if you know that information that you require for your own unit, together with an ongoing strategy, continuously reacting to outcomes, you will have the optimum cesarean section rate. And that section rate will be different, maybe at different times in the same population, but actually possibly be different in different populations. And we've got to accept that as a rational and acceptable possibility. So what information do we need to determine an optimal cesarean section rate? Well, this is my view. To start with, you need a structure. And you might expect that I would say this, but you need the 10-group classification system. Not the more sophisticated with all the modifications and adding this and that, but a basic 10-group structure. And remember, the 10-group classification system, and I'll go into this in a moment, is being popularized for cesareans, but it's far more important than that. It's a perinatal classification system. You need to know your indications for cesarean. And the problem with that is that we have no accepted classification for that, something that we have done a lot of work on and will be publishing more. And I'll be presenting some of that later on. We need to know the case mix, including significant epidemiological factors, how they vary overall, and indeed in the different groups in the 10 groups. We need to know the perinatal outcomes, maternal and neonatal. We need to know complications. We need to know long-term and the short-term. So those are the 4 main levels of information. But then we need to be able to describe our processes. And these processes, they may be right, they may be wrong. Different people have different views. But we need to know our view on all of these different processes and what the culture. And therefore, you can look at your results, the first 4 level, and somebody will say, well, those are very good results. What are your processes? Or likewise, you may be doing the same thing to somebody else. Okay, let's start with the 10 groups. It's not just me that thinks it's important. The big international bodies, the WHO statement on cesarean section rates which I'm sure you're aware of, are saying a lot of the same things. Let's start to collect data uniformly, so the near future we'll be able to move our focus from rates at population level to monitoring and discussing cesarean section rates and outcomes in each group. Only then will we have the data and evidence that will lead us more clearly to actions to improve care. So not that randomized controlled trials aren't going to be useful, but routine data collection, like in businesses, sports organization, and a lot of other big organizations, they depend on good routine data, clearly and well collected, timely, and stratified in the appropriate way. So apart from the WHO, and the WHO actually have done a lot of work on this. Some of you may be aware of the implementation manual, which helps you implement the 10 groups, which is very worthwhile looking at. But also they're moving to a Robson classification platform now, where you're going to be able to put anonymously, otherwise, your data, share the data, access other facility data, and access other practical resources. I'm involved with that, and I will be giving, if so desired, opinions or ideas about interpreting the 10 groups, including my own opinion about it. FIGO have supported it. Again, very, very much the same principle behind it, that it should be instituted, that the results be made available for purposes such as quality control and auditing, and also the collection of other events and outcomes. That's crucial, and that's crucial to understand the classification, because any of the events, outcomes, or processes can be analyzed at the same time as cesarean section rates within the classification system. EBCOG, I know India is not in Europe, but EBCOG again has strongly supported it, saying very, very much the same things, and you'll be able to read these in more detail at your leisure. But just finishing off, EBCOG recommends that national data are collected in such a way that the classification will allow meaningful comparison. There is a need to learn from one another. And when events occur so frequently in such a kind of at least semi-standard way in terms of delivery, then we should be able to get more information from that. Interestingly, just recently, a House of Commons in the UK issued a report, The Safety of Maternity Services in England. And this is the government making the recommendation, not a professional body. It is deeply concerning that maternity units appear to have been penalized for high section rates. We recommend an immediate end to the use of total cesarean section percentage as a metric for maternity service, and that this is replaced by using the Robson criteria to measure cesarean section rates more intelligently. NHS England and Improvement must write to all maternity units to ensure that they're aware of this change. So it's not necessarily only professional bodies in some countries that are saying that we should do it. It is actually governments that are saying it. And this is what I meant by, the first slide, and saying that it's governments that are interested in this as well. But they don't realize really that it's not only cesarean section rates that you can monitor, but you can monitor many other things too in relation to the cesarean section rates. So this is the standard table. And I've read a lot of papers from India, and it is very disappointing to me that people always use their own kind of table. This is the standard table, and indeed unclassified doesn't actually have to be in the table. It could be underneath, but this is the standard table. There should be nothing else. There should be no subgroups. Obviously, you have to divide it up into subgroups. Obviously, you need a lot of other epidemiological factors, but the starting point, that is the principle of the 10 groups, must be standard. Must be the same font, must be the same size table. And that is one of the reasons that the 10 groups were chosen, and no more and no less. And indeed, the way that the groups are placed on the slide is really important, so that you can get most information. One of the points that people make is group 2 should be divided into inductions as cesarean sections before labor. Of course it should be, but not on the first slide. The first slide, groups 1 and 2, differentiates very easily visually and in any of the figures the number of women that proceed to go into labor spontaneously, as opposed to the number of single cephalics pregnancies that the pregnancy is interrupted. What one obstetrician may induce, another may deliver before cesarean. And it's one of those examples by giving that is so true. When you give more detailed information, the viewer takes less information away because the eye can't, or the brain can't take it all in. Less information sometimes is more. Now, I'm not going to go through the 10 groups at all here. That's for another lecture, but it's very important, a standard presentation. The philosophy is based on the premise that all information will be more relevant by stratifying them using the 10 groups and their subgroups. But not only individual bits of information, they'll be more relevant in relation to other bits of information within those 10 groups. Now, level 2 information is indications for cesareans. And at the moment, there is no accepted international classification for indications for cesarean section. The most common operation, certainly in women, if not overall. And I would describe it as I see it. It's a mess. And it's a mess because we can't agree. All kinds of different definitions, and they overlap and nothing consistent. It's quite strange, really, when you think about it. The 10 groups will tell you which women, but they won't tell you the indications. And as many papers have pointed out, the 10 groups doesn't do that. I accept that. We have our classification of indications, but we use it within the 10 groups. But that doesn't mean to say that it should all be one table at the beginning. The problems with indications are definitions. And once we have the definitions, do we apply them appropriately? Some people seem to be very happy in putting about 8 indications down, which fine, may describe the clinical situation. And I'm not saying they shouldn't be there, but as a means of auditing and classifying things, it's next to useless. There's a growth of indications. In fact, there is no indication, and that's very difficult to define. But the whole problem about indications is that they're all retrospective. They're all after the event. So unless they are described within a prospective classification system like the 10 groups, they're not going to be of any value. The first thing you need to do with indications is to divide all women that have a cesarean into either pre-labor, which may be elective or emergency. Elective and emergency shouldn't be used, in my view, first up. All cesarean sections after spontaneous induced labor are some degree of emergency, but all pre-labor sections are not all emergency, and indeed they're not all elective either. They may be elective. So pre-labor and spontaneous and induced, and there should be indications for both those two divisions, but they're different. And I'll show you why I think they're different. So if you look at our cesarean section rate, which has gone up a lot, 31.4%, you can see that of the 31.4, 2/3 of the cesarean sections are done before labor. No amount of change to labor will actually affect that, unless it changes perception of view of labor, and therefore then they're more likely to go into labor. But our, at the moment, contribution to the 31.4%, i.e. sections after spontaneous labor, is only 1/3. And you've got to be aware of that if you're looking to make changes, if you feel you want to reduce the cesarean. I believe strongly that for pre-labor cesarean section, they should be all divided into either fetal, maternal, or no medical reason. Now, I know what some of you are going to say, that yes, there may be a bit of fetal, or there may be a bit of maternal, or no medical reason. But for most pre-labor cesarean sections, it's either one of these, which is the main one. But within that main indication, but stick to the main one. But within that, you can describe the other things that contributed it. But it's very important to commit to either one of those for pre-labor cesarean sections. Sorry, that slide should contain pre-labor sections as a heading. Maternal request, my own definition for this is at the time of the request, in the opinion of the obstetrician, which may be different, there is a greater relative risk of a significant adverse outcome to mother or baby by carrying out a cesarean section than awaiting spontaneous labor or inducing labor. So in my view, a woman with one previous cesarean section, unless there's a other medical reason to deliver one previous cesarean section at 39 weeks, unless there's some other reason, is not a medical reason to deliver by cesarean, because if it is, and you feel it is, you should be doing it in everybody. However, and you should record the reason why the mother requests it, but it's basically a request which has come from the mother. But if a woman with a previous cesarean section gets to 41 weeks and it's unfavorable, and whether she requests or not, I would be advising her to have a cesarean section. I wouldn't induce a previous cesarean section, which is unfavorable. But definitions like this should be included in that level 5 information of processes. But the most important contribution I think I have is the classification that we use after spontaneous and induced labor now. And I want to explain it like this. We do need an objective classification of cesareans in labor after spontaneous induced once it started the induction process. I do believe oxytocin needs to be part of it. And the classification should be able to be used irrespective of how you manage labor. There's too many classifications in labor and delivery that depends on a method of managing labor or diagnosing dystocia. I think we have to move away from that, and we should let the results speak for themselves and then look at the processes, because otherwise we're never going to get agreement. And this is what people have failed to understand over the years, that we have never managed to agree the definition for no progress and when we should do a cesarean. Every case is individual. And the 3 questions that may help us is the indication for cesarean, either fetal, no oxytocin, or dystocia, something we call dystocia, poor progress. I do believe the dynamics of the labor should be included. Has cervical dilatation been more or less than 1 centimeter an hour? I've chosen 1 centimeter an hour arbitrarily, but you could have divided up into 0.5 centimeters an hour. And was oxytocin used? And if you do that, you end up with this. And you may not have time to understand this completely today, but I believe that this is going to be used more and more in the future. There's more and more countries beginning to use it, like the 10 groups, but it suddenly grows and more people. So it's really grouping women together who have a cesarean. So it's actually saying after spontaneous induced labor, there are only 2 reasons really why you have a cesarean, either for a fetal reason, but importantly, no oxytocin is being used, or something we call dystocia, failure to progress. Fetal, don't worry about the definition. It could be anything. It could be a CTG. It could be bleeding. It could be meconium 3. It doesn't really matter. The important point, no oxytocin was used. And dystocia, likewise, the actual definition for poor progress is not the issue. It's the issue that it was progress rather than anything else. Now, it divides progress, the dynamics of progress, using the 1 centimeter hour into 2 kinds of partograms. And this is taken from the time that labor is committed to or diagnosed to the time either you end up having a cesarean section or the time you get to full dilatation. So what it's saying is what's important in the dynamics of labor is not only what centimeter dilatation you reached, but the speed at which you reached. It's not saying right or wrong. It's not having any implications for how you manage labor. It's just stating a fact. And we've arbitrarily called less than 1 centimeter hour inefficient uterine action and more than 1 centimeter an hour efficient uterine action. And if you have confirmed efficient uterine action, then the only reason for a cesarean section is most likely to be either persistent malposition or CPD. Now, if it's less than 1 centimeter, it doesn't mean to say that you wouldn't have some babies that would be probably CPD or malposition. But the point you're making is those labors, there was not good progress in terms of centimeters, more than 1 cent. There wasn't good progress in terms of centimeters per hour, and the progress was less than 1 centimeter hour. Now, this group is divided into poor response, inability to treat overcontracting, inability to treat fetal intolerance, and no oxytocin given. And in this group, you've given, according to your regimen and your diagnosis of poor progress, treated with oxytocin, you got up to the maximum dose and no progress occurred. Baby was fine, mother was fine, and no problems at all. But in the end, at some time or other, at different levels and different units, you gave up and did a cesarean. This group is that you treated with oxytocin according to your guidelines, but you couldn't get it to the maximum dose of your oxytocin regimen. And therefore you had to stop at a certain dose because of overcontracting. And if you ended up with a cesarean section, it's described as dystocia, inefficient uterine action, inability to treat, overcontracting, because you didn't get up to the maximum dose. You can have a similar one where you were unable to get to the maximum dose because the baby didn't tolerate it. That's not fetal distress, because the initial problem was dystocia, but when you treated it, you couldn't get up to your maximum dose. You had to keep it at a safe dose, and progress may not have progressed, and in the end, you deliver by cesarean. In the literature, this group, inability to treat fetal intolerance, is often mixed up with this group. And that is wrong. It's a completely different etiology. This was without any dystocia or treatment of dystocia. This fetal intolerance only occurred after you try to treat, and often the baby is fine once you stop the oxytocin. Lastly, there's a group where you don't give oxytocin, and that may be more prevalent in most units with a woman with a previous scar. So you may have a woman with a previous scar that goes into spontaneous labor. There's no progress, but you section for dystocia, inefficient uterine action, but no oxytocin was given, i.e. you were happy for her to go into labor and see whether she progressed, but not happy to treat with oxytocin. Now, once you look at this within the 10 groups, but predominantly groups 1 to 5, possibly group 8, you will get results. And those results will give you an idea how you may reflect on your processes and how you may change them. And indeed, if you're able to compare it with units that have different results and also different processes, that's the point you may learn, and we may learn from each other. Other levels of information, you need the age, you need significant epidemiological factors, age, body mass index, other medical conditions, culture and choice, but they again need to be analyzed within the 10 groups. You need perinatal events and outcomes within the 10 groups, and I list them here, but there may be others, but they all need definitions. But those levels of information are required to validate an optimal cesarean section rate. And you also need to know things like complaints, adverse incidents, medical legal cases. And have you ever thought of analyzing them according to the 10 groups? If all the complaints are from group 1, or if all the complaints or adverse incidents are from group 1, if all the medical history group 1, that provides the focus, if you like, to look at that group. And then you need to know all your process. You need to describe them, you need to think about them, and you need to consider them. And if you are lucky enough, or if we're all lucky enough to have different results, but we use the same classification system, and then we can compare processes, that's when I think we will learn from each other. So validation of the data quality and the clinical interpretation is possible because of the relative homogeneous nature of the 10 group classification, and also because of the consistency of many of these events and outcomes and complications within the groups. Once you start looking at them, and with a good routine data collection system, which is the real problem, I think. We're very happy to fund randomized controlled trials, but we seem less happy to fund routine data collection, which is the main issue. Then it is remarkable how certain events and outcomes, how consistent they are within these groups. So in summary, yes, there is going to be an optimal cesarean section rate, but it's not a particular number, and it's never going to stand still. This is what we've got to appreciate. There may be absolutely good reasons why the cesarean section rate will vary in one unit from one period of time to another, and why it may vary between different countries, or indeed different units within the same country. But you need to prove it. You need to be interested, and you need to provide the information. And those are the level of information that I think you need. It will depend on how much you can demonstrate that you understand it and the implication it has on mother and baby. And how you achieve that, it will depend on the way you collect the information, the professional's knowledge of the information in a standard way. I would err towards understanding the basic principles of the 10 groups, the ability in an organization to respond and change as a result of information, and the continual ability to reassess information and react quickly. And then you will have the optimal cesarean section rate. So thank you very much, and I hope you find that helpful. But we're only at the beginning of this journey. nowhere near the end. Thank you.
Thank you, Dr. Robson, to actually log in live also. And definitely you've given a big area for all the people who are concerned about rising cesarean section rates to justify every single cesarean that we do. I have listened to it second time, so I have a small query that in that algorithm that you explained, the column which said inefficient uterine action and no oxytocin given. So then what will be the reason for the doctor to do section? Because what our understanding is that if it is a fetal distress, of course, but if the uterine action is not efficient and there is no, then what will be the reason to do a section? Can't we wait? I mean, I was not able to understand that point.
No, thank you for the question, and I'm delighted to join everybody. No, of course you can wait, and you can wait longer, but it's in clinical cases where the risk of giving oxytocin outweighs the risk of not giving it. So in group 1, in spontaneous labor, I would agree with you. I would be very interested in any unit that doesn't give oxytocin. And why not? But there are units in the world that do that, and it isn't until you record that that you find out. So actually seeing how many have a cesarean section for dystocia, inefficient uterine action, no oxytocin in group 1, you like me would agree that's very significant. Why is that? But in group 5, a woman with a previous scar that is trying a VBAC, and remember, this classification will be applied to all the groups, then I would absolutely accept that. I would encourage that women are trying to go into labor, and while we would be happy clinically for them to go into the labor, there is no progress. But, you know, the head is a little bit high and the contractions are there, but then they're not too strong. I absolutely would not give oxytocin. So I hope I've explained that. For a breech, for example, you might allow them to go into labor, but you wouldn't give oxytocin. But it really is looking and grouping these women together in the different groups.
Okay.
So thank you so much. That was a very wonderful oration. I would like the technical team to share the oration scroll, which we are very proud to present to Dr. Micheal Robson, the annual conference of Perithalmana ONG Society, NOESIS 2 conference organized under the aegis of Practical Obstetrics Committee of FOXI. NOESIS 2 Oration 2021 has been conferred on Dr. Micheal Robson, consultant obstetrician and gynecologist, the National Maternity Hospital, Dublin 2, Ireland, for the topic, is there any optimal cesarean section rate, during NOESIS 2 held on 12th September 2021 on virtual reality platform. By bestowing this oration on him, we acknowledge not only his continued contribution to the field of obstetrics and gynecology, but also for being a beacon of light for members of varied generations to explore, comprehend, and dedicate the discoveries for overall patient care. Wishing him many more years of academic excellence, dated this the 12th day of September 2021. Dr. Kunjumoyuddin, Chairman, President POGS and Chairman the Organizing Committee, Dr. Abdul Wahab, Secretary POGS and the Organizing Secretary of NOESIS 2.
Thank you very much. It's a big honor, and I love the online scroll. Yes, very good.
Yeah, you will be receiving it, the hard copy of the scroll
as well. Okay.
Your address.
Thank you. And I've listened to some of the talks from the conference, and yes, there's been some very interesting and good talks. So a lot of hard work